You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology. And this is This Week in Cardiology for September 8th, 2023. This is part 2 of an ESC Recap. This week, ECMO, the FIRE trial, MULTISTARS-AMI, Iron-Supplementation in heart failure, and pacing in sick sinus syndrome. In this part 2 ESC review, most of the trials for which I make comments, I do so as a neutral Martian, that is, an outside observer, focusing mostly on data. The previous ESC review last week involved a lot of trials in my area of electrophysiology, but these are different. So if those with content expertise think I missed some nuance, please do comment. And last week we had a few great comments, and our ratings are a little up from last week, so keep it up. Ratings and reviews really help others find this podcast, so please continue to do that. All right, let's go. First topic, cardiogenic shock. The clear leader in this podcast has to be the ECLS-SHOCK trial of extracorporeal life support in cardiogenic shock due to acute MI. Now, I choose important trials on the basis of two big criteria. One is how they answer a specific clinical question, and secondly, what they teach us about medical science. ECLS-SHOCK trial fulfills both these criteria and even has a bonus, and that is bravery. Now, a couple brief background points. Cardiogenic shock due to acute MI is bad. Death rates are high despite all that modern cardiology can deliver. The problem with cardiogenic shock is poor oxygen delivery due to pump failure. Opening closed coronaries will help, but recovery of pump function takes time. And this core problem leads doctors to look to mechanical circulatory support, replace or assist the heart's function as a pump during this time of injury as hopefully a bridge to when reperfusion helps improve things. ECLS, also called veno-arterial ECMO or extracorporeal membrane oxygenation, is a way of providing mechanical support during the time of pump failure. Its use has risen 10x over the past 10 years. ECLS is seriously invasive, right? It requires large bore access to the central veins and the femoral artery. Recall patients with AMI just had PCI, and they're going to be on high-dose antiplatelets, so that's no small thing. Blood is routed to an extracorporeal circuit where it is oxygenated. It is then sent back retrograde in the aorta. There's tons of flow adjustments that require lots of human expertise. Doctors choose mechanical support in the setting of cardiogenic shock due to MI because it is therapy directed at the problem, which is a lack of pump function. But there is scant data to support this practice, even though it makes sense. In fact, the current data is downright depressing. I mean, start with the intra-aortic balloon pump. These trials have been found really to be non-significant. A smaller trial called ECMO-CS, published last year, found no benefit. So the ECLS authors set out to do a more definitive trial. The first author and trial leader, Professor Holger Thiel from Leipzig. So slightly more than 420 patients were recruited from multiple centers, all had cardiogenic shock due to MI. Half the group got VA ECMO, the other half standard of care. These were 63-year-old patients, mostly men. The primary endpoint was very clear and simple, death at 30 days. And the results, there was no significant difference, 48% versus 49%, hazard ratio 0.98. Safety outcomes were way worse in the VA ECMO group. Moderate or severe bleeding, 23% versus 10% respectively. That's more than double the risk of a bad outcome bleeding-wise. Peripheral vascular complications, 11% versus 4%. That's nearly 3x higher in the VA ECMO group. Okay, my comments. First, a bonus. This is a brave study because it required taking people with pump failure and not putting them on a life-supporting therapy. It sets a really good example for the cardiology community that these trials can be done and provides often surprising results. Second here is the specific message, and that is that VA ECMO does not work in cardiogenic shock due to MI, period. There was no signal of death reduction and 2 to 3x more serious complications. Now, there was talk about patient selection, trial conduct, this and that, but you already have one null trial last year, and now you add this more definitive trial. The authors also spent many words discussing why VA ECMO did not work in the manuscript. I don't think this was necessary and probably was done to placate peer reviewers or the editors. This could have been the shortest discussion section ever published. In fact, you barely need a discussion. You could just give the results. They're so clear. Specifically, I think don't do VA ECMO in this setting. I also think this puts a serious damper on all kinds of mechanical support in cardiogenic shock, though we definitely want to await the upcoming Impella trials before making any judgments, say, based on observational data. Now, the third comment is a general lesson about medical science, and I've said this many times. Always be cautious of doing things that make sense. Yes, on paper, VA ECMO supports the low cardiac output. It's plausible. But that plausibility thing is way too low a bar in medicine. You have to show something works to reduce an important outcome in real patients in a trial. If Professor Thiel and his colleagues had not been curious and not been brave, we would be doing this invasive procedure for years. We'd be harming patients and not knowing it. ECLS-SHOCK is a shining example of why we need a culture of randomization in this profession. Many, if not most things, can be tested in RCTs, and that is going to be a theme of this podcast. Second topic is the FIRE trial. The question in the FIRE trial centered on the strategy of treating older patients with acute MI who also have multivessel disease. There are two choices when these patients are in the cath lab. One is to fix the culprit occlusion and treat the others medically. Or, second choice, fixing the culprit and doing other significant lesions with PCI at that time. Culprit only or complete revascularization. There is a general consensus that in younger patients, complete revascularization is preferred, though I'm not sure how strong the evidence is for this, as the largest trial, the complete trial, found no difference in CV death nor all-cause death. But for the sake of argument of this podcast, let's accept the consensus that complete revascularization in younger patients is the preferred strategy. Now, we know from last week's most important trial called the FRAIL AF trial, what works in younger patients may not work in older patients. So Italian investigators enrolled older patients, mean age 80, who presented with either STEMI or non-STEMI to complete revascularization guided by physiology assessment or culprit-only PCI. The first author is Simone Buscaglia. The primary endpoint was a composite of MACE, death, MI, stroke, or ischemia-driven revascularization. This is important. Patients were randomized after successful culprit PCI was done. After. About 720 patients in each arm. For reference, the seminal complete trial enrolled nearly 3 times more, about 2,000 patients per arm. The composite MACE endpoint occurred in 21% of patients in the culprit only versus 15% in the complete arm. That hazard ratio was 0.3, 0.57 to 0.91, with the confidence intervals, the p-value significant to 0.01. Death from any cause, 12.8 versus 9.2. That hazard ratio was 0.70. MI, 7% versus 4.4%. Hazard ratio 0.62. Stroke, too small numbers to say anything. Revascularization, 6.8 versus 4.3%. Again, hazard ratio 0.63. So all components were contributing to the MACE reduction. Safety outcomes, which were AKI, stroke, bleeding, showed no difference. So my comments, the results here are pretty clear. The lower rates of the primary outcome are statistically and clinically significant. 3 of the 4 components of the primary outcome are positive for complete revascularization, and safety was not different. I am surprised, right? First, it's unusual that older patients have stronger effects than younger patients. That's usually because of competing risks. Second, after you fix the culprit, you are essentially treating stable disease, right? And there's no signal that revascularization improves outcomes over medical therapy in stable disease. So I'm surprised. But the results are the results. Although there were far fewer patients in FIRE as opposed to complete, FIRE did have a higher event rate, which is expected because they're older patients. Now, one caveat the authors point out may have been important is that non-culprit interventions were guided by physiology, which has the main effect of reducing the number of PCIs. The authors note that 483 non-culprit vessels, more than 50%, were not treated with PCI on the basis of this physiology measurements that did not indicate the need for revascularization at the time of functional testing. Now, based on the totally biased FAME-2 trial of FFR, I'm not completely sold on physiology-based guidance, but I have no trouble believing that anything that reduces non-culprit PCI is going to be a good thing. I think the main problem with translating this evidence are that it is open label and randomization was done after culprit PCI. So first, patients in the medical arm know that they have other bad blockages that were not treated. That may not influence death, but it surely influences ischemia-driven revascularization. I calculated a fragility index of 9, meaning if 9 patients in the control arm were converted from not having a primary outcome to having a primary outcome, the study would lose significance at a p of 0.05. That's not a lot of revascularization decisions in a trial of older patients with acute MI. Second, randomizing after culprit PCI affects how we translate this evidence, meaning interventional cardiology doctors are unlikely to randomize patients into this trial who have complex non-culprit PCIs. So to me, sitting outside as a non-PCI doctor means that I would not translate this evidence to people with complicated non-culprit lesions such as a CTO. For instance, when you just look at the patient characteristics, more than 1 in 3 of these non-culprit PCIs were in the circumflex or ramus. Caveats aside, though, this is strong evidence. It surprises you, and that fact adds heft to my contention in the first segment of this podcast that randomization is one of the most important innovations of modern medicine, period. For if we were guessing, we would have guessed that older patients would have benefited less, not more, from complete revascularization. So, interventional cardiologist, if you feel differently about my comments, please weigh in. Okay, third topic is another trial along this line called the MULTISTARS-AMI trial. The FIRE trial, taken together with previous data from COMPLETE, argue for complete versus culprit-only PCI when patients have an acute MI and multivessel disease. Now the question is how best to accomplish complete revascularization. And there are 2 choices. You could do it all at once in the index procedure right after stopping the MI, or you could do it in a stage 2nd procedure in the days to weeks later. Lead author Barbara Stalali and colleagues in the MULTISTARS-AMI trial set out to answer that question by randomizing more than 800 patients who had STEMI and multivessel disease to immediate multivessel PCI or PCI of the culprit followed by staged multivessel PCI within the 14 to 45 days after. Their primary endpoint was again MACE, death, MI, stroke, ischemia-driven revasc, or heart failure hospitalization. These were 64-year-old patients, mostly men, mostly white. The authors designed the comparison as a non-inferiority trial with immediate as the new treatment and staged as the standard. The results were crystal clear. A primary endpoint occurred in 8.5% in the immediate group compared with 16.3% in the staged group. That's a risk ratio of 0.52, a 48% reduction. Confidence intervals tight, p-value highly significant for non-inferiority and superiority. MI and revascularization were the drivers of the benefit. Death, stroke, and heart failure were not much different. Serious adverse events favored the immediate strategy. 104 versus 145 patients had adverse events in the immediate versus stage strategies. So my comments and limitations. This data does not apply to complex disease like CTO's left main, vein grafts, or cardiogenic shock, as these patients were excluded. We also have the same translational issues as we did in FIRE, namely that patients were randomized after successful culprit PCI, so interventional cardiologists are choosing which patients to put in his trial based on the knowledge of the anatomy. Now, one question I have is why the non-inferiority design? It's not clear to me that doing all of the PCI revascularization in the first procedure offers that much of a safety or cost advantage. Maybe it's a slight convenience advantage. To me, a straight superiority comparison would have been better, but any experts on this, please weigh in. Another issue here is that the drivers of the MACE primary endpoint were not the strongest or hardest endpoints. It was ischemia-driven revascularization is a difficult endpoint because it is so decisional, right? Doctors and patients, and it's certainly more susceptible to any non-nefarious biases. MI could have also favored the immediate group because any periprocedural MI in the initial procedure will be hidden because there was a STEMI, whereas any periprocedural MI a month later would be obvious. CV death, heart failure, stroke were all the same. So yes, immediate multivessel PCI seems reasonable to do, but I could see a scenario where a clinician might decide staging is better, say it's the middle of the night, or something like that. I'd hate to see guidelines or quality measures strongly incentivize docs to algorithmically choose immediate multivessel PCI based solely on this trial data. All right, next topic, a little different, heart FID trial. Now, patients with heart failure, iron deficiency is common and contributes to symptoms. Now, when important things are low in the body, doctors look towards replacing them. Thus, the IV iron replacement strategies were born. A handful of small trials hinted at benefit, but neither were statistically robust. The heart FID trial was designed as the trial to answer the question. 8,000 plus patients were screened to enroll 3,000 patients randomized 1-to-1 to iron infusions or placebo. The primary outcome was a hierarchical composite of first death, then hospitalization for heart failure, then change in 6-minute walk test. Now the significance cutoff here was set at P of 0.01. This significance level, which is a little different, fulfilled a special protocol agreement with the FDA that permitted the assessment of efficacy based on a single randomized trial. Patients were about 69 years old, mostly male, mostly white, and about half had class 2 and the other half had class 3 heart failure. They had low ejection fraction of 31%. The mean hemoglobin was 12.6 and the mean serum ferritin 56. Now, the results were similar to the previous iron infusion trials, almost there but not quite there. The deaths 8.6% versus 10.3% in the iron versus placebo arm. Heart failure hospitalizations, 297 versus 332 respectively. The delta in the 6-minute walk test, really no significant difference. So the overall win ratio, where you combine this hierarchical endpoint, was 1.10, but confidence intervals went from 0.99 to 1.23. That's a p-value of 0.02, which is higher than the pre-specified 0.01. Secondary outcomes of CV death or heart failure, this was 0.93 hazard ratio, with the upper bound of the confidence interval is 1.06, so clearly not significant. So the authors write, quote, "We found no apparent difference between the ferric carboxymaltose group and the placebo group with respect to the primary outcome, which was a hierarchical composite including death, heart failure, hospitalization, change in 6-minute walk test. Results of a pre-specified sensitivity and supportive analysis appeared to be consistent with results of the primary analysis." Now, at ESC, there was also a patient-level meta-analysis of these trials of iron replacement. These are CONFIRM-HF, AFFIRM-HF, and HEART-FID. It was published in the European Heart Journal, and there was a trend towards reduction of the co-primary endpoint of CV death and heart failure. They found a hazard ratio of 0.87, but again, the upper bound of the confidence interval goes to 1.01, and the p-value is 0.08, so it doesn't make statistical significance. When I look at this data taken together, it is hard to get excited. Iron infusions are burdensome for a patient. It takes time, a trip to an infusion center, and it's not free. Heart failure patients already incur many burdens of being a patient. When we assess whether a therapy is worth recommending, we consider the effect size and the statistical robustness of the findings. I'm just a neutral observer here. I have never prescribed iron replacement. I have no conflicts, but to me, the effect size seems not very clinically significant, nor is it statistically robust. I don't think this therapy on average in these trials makes a big difference. Now, could there be people with super low iron stores, super low transferrin saturation levels that might gain more? Maybe, but on average, I'm not seeing it. Again, as I did in the 2 previous trials, I assess here as an evidence person only who has everyday cardiology knowledge but no specific content expertise, so let me know if I am off base here. Now, next trial I know a little bit about. This is the DANPACE II trial. Sick sinus syndrome, or now the new name, sinus node dysfunction, is one of the most common bradycardias you'll see. The reason is its main cause is birthdays. Patients live longer, they get sinus node dysfunction. You're going to see more as patients live longer. When this bradycardia causes enough symptoms, we place a dual-chamber pacemaker. So as to provide bradycardia support, we mostly pace in the atrium. Now, many of these patients with sinus node disease develop paroxysmal AFib. And in my entire career, experts have wrestled over how best to prevent the AFib seen in sinus node dysfunction. Some have advocated for higher rates of pacing and pacing overdrive algorithms. The idea here is that higher rates of pacing will sort of smooth out the electrical properties, the refractory periods, and this business sort of act as an anti-fibrillatory therapy. But boom, another idea that makes sense. I bought into it, but then over the years, I started to see that it really doesn't work. Patients may feel palpitations, and longer-term trials have really not borne out that higher rate pacing has been beneficial. But then the pendulum flipped to let's minimize atrial pacing. Let's let the atrium do its own thing and not bother it at all with pacing. So a Danish team led by Dr. Mads Brix Kronberg from Aarhus in Denmark designed the DANPACE II trial. This is an elegant and simple trial. 540 patients who got a pacemaker for sick sinus syndrome. One group gets a base rate of 60 and rate responsiveness, DDDR pacing at 60, standard, out-of-the-box stuff. One group gets a base rate of 40 and is set DDD, no atrial rate responsive pacing. So the DDDR 60 group paces in the atrium about half the time. The DDD 40 group paces about 1%, so a major difference in the amount of atrial pacing. The primary endpoint of first AFib occurs in 46% of both groups, hazard ratio 0.97, p-values like 0.8, absolutely no difference. There were no between-group differences in atrial fibrillation exceeding 6 or 24 hours, persistent AFib, or cardioversions for AFib, no difference. However, the incidence of syncope or pre-syncope was higher in patients programmed at 40 beats per minute. So my comments, here we have two big themes. One is the specific question of programming patients who have pacing for sick sinus syndrome. This is something that electrophysiologists care about. The trial shows no AFib prevention from lower rates and a higher rate of syncope, so we can program in the normal way at a base rate of 60 and use rate-responsive pacing. That's good to know that avoidance of atrial pacing does not decrease atrial fibrillation. Question answered. Good. The second theme, though, gets back to the epistemology, the ways of knowing. The team and our host did not go about answering this question by putting up charismatic key opinion leaders who wear Italian suits. They did not do retrospective observational studies. No. They designed and conducted an elegant randomized controlled trial, and they showed it can be done, and it answered the question. And so I say, good on them. Thank you for doing it. And that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating, write us a brief review. If I'm wrong, let me know, write a comment, tell me. I learned from your comments a lot, so thank you. Till next week, this is John Mandrola from the heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.